So I'm going to be demonstrating a synchronised electrical cardioversion. This is indicated for use in patients who have cardiac arrhythmias and includes atrial fibrillation, atrial flutter, SVT, supraventricular tachycardia, and perfusion VT. The differential diagnosis of perfusion VT, which is what I'm going to be demonstrating a cardioversion for, is SVT with aberrancy, as this can mimic VT. However, VT is a likely diagnosis when you can see capture beats or fusion beats in your 12-lead ECG. So today I've been called to a 76-year-old male. He's been complaining of chest pain, some palpitations feeling like they're going up to his neck, and he had an MI 5 years ago, but the presentation of his chest pain today is very different to that. Okay, so a primary survey has been done. He's unable to obey commands, and a 12-lead ECG has been taken. And this has determined that he is in VT, although he has a pulse of 170. So I've asked my off-siter to take some vitals, and they've given them back to me as a heart rate of 170, blood pressure of 70/40, rest rate of 18, blood glucose of 7.6, and a temperature of 37. So with those vital signs and the fact that he cannot obey commands, I'm determining that he is in severe level of cardiovascular compromise and an electrical cardioversion is needed. If he was able to obey commands, I would need to phone clinical desk for permission to administer ketamine through IV. AUT1 cause control.
AUT1, go ahead.
Can I please request an R50 for a status 1 patient preparing to cardiovert?
Sure, it's going to be about 20 minutes.
Copy, 20 minutes. So to perform this, I'm going to be using my cardioversion checklist. I've also got my resus handy here with my BVM in here, just in case anything should happen. Okay, so we've determined the level of cardiovascular compromise is severe for this patient because of his markedly abnormal vital signs and his inability to obey commands. And we've also used a 12-lead ECG. And this ECG here shows that he is in VT. Okay, so we're going to cardiovert and we're going to use the cardioversion checklist in the CPGs. So we're going to ensure the pads are placed in the apex sternum position, which is the preferred position over anterior posterior. So that's done. We need to ensure the defibrillator is in manual mode and select the lead with the visible R wave. Determining that is lead 2. And just going to wait for that artifact to minimise out. So that's minimised now. I'm going to select synchronised mode. Confirm there's a detection symbol above every QRS complex. And this is when sedation would be administered at times when it is indicated. And we're then going to select the joules, so the maximum joules possible for each monitor. So we're going to charge the defibrillator, make sure everyone's standing clear, everybody clear, and going to hold the shock button down and shock. Clear, shock in, shock's delivered. Okay, so shock is delivered. We're then going to go and determine the rhythm to see if that cardioversion has reverted the rhythm, and in this case it has. So he's now in a sinus rhythm. His heart rate is decreasing there. So I'm just going to wait for that to decrease. So he's in sinus rhythm. That cardioversion has been successful. We also need to redetermine the level of cardiovascular compromise. If, however, he was still in VT and still severely compromised, we would go and cardiovert one more time. We'd ensure the defibrillator was still in synchronised mode and also make sure the patient has got adequate sedation on board if necessary. So now I'm going to be demonstrating RSI preparation and RSI assistant. So the scenario today is we've been called to a 40-year-old male who's fallen 6 metres onto concrete. He's got an isolated boggy patch to his occiput and he is a GCS of 6 made up of 2, 2 and 2. Okay, so I have gained some IV access large bore bilaterally. We have also drawn up some morphine which we can administer for any combativeness from pain, as he may become a little bit agitated with the injury to the back of his head. And we're also going to be considering some differential diagnosis for this patient. So if he's falling, we're going to be looking at whether it was a slip, a trip, or whether it's from a medical event such as hypoglycemia. So I've asked my offsider to take some vital signs for me, and they have given them back to me as a heart rate of 50, a blood pressure of 160/90, a rest rate of 12 but it's irregular, a blood glucose level of 7.6, ruling out hypoglycemia, and a temperature of 37. So with the blood pressure, we don't currently have any fluids running, but it's connected to one of the IVs ready to turn on if necessary. Okay, so the indications for RSI is a GCS of equal to or less than 10 and clinically significant airway or ventilatory compromise. So this patient has got a GCS of 6 and there's some ventilatory compromise with irregular breathing at a decreased rest rate. So AUT1 calls control.
AUT1, go ahead.
Can I please request an RSI capable R50 to perform an RSI on a status 1 patient, please?
Sure, stand by. Okay. AUT1.
Go ahead.
Yes, the R50 is coming to you in 10 minutes and they've asked that you start preparing for RSI.
Copy, thank you. Okay, so I'm going to use my RSI checklist in my CPGs, and so the first thing I need to do is attach some nasal prongs without oxygen. Take his oxygen mask. I've already got a reservoir mask on at 10 litres per minute due to his TBI, but I'll just pop those underneath and have that ready there. Okay, so as I said, we're already pre-oxygenating at 10 litres per minute. I have got my bag valve mask here with PEEP set at 5, and I'm just going to leave that there ready to go. I've attached my ECG, blood pressure cuff and my SpO2 monitor, and that's all hooked up to the machine there. ETCO2 cable is plugged in. I'm just going to attach that to my BVM mask, and that's there should we need it. So then we need to position the monitor so that it's in a place so that everybody can see it. Here, that's in a good place for us all to have a good view of it. I'm also leaving the space to the right of the patient's head free so that the intubation roll can be placed here. We've got bilateral large bore IV access, and a running line of sodium chloride has been drug checked and prepared. It's currently off, but it can be turned on when needed. Okay, so we've got the patient in the sniffing position with a towel placed underneath his head. We've got rolled up towels on either side to support any C-spine injuries that could be evident. Okay, we then need to place an ETT holder underneath his head. We've already tested our suction unit, that's working fully. We would test that again. I'm just going to place this just underneath his head here so that's easily accessible. We've already prepared our manual ventilation bag with PEEP set at 5. I've asked my offsider to obtain some vital signs, and I will ask them to keep on retaking vital signs to further monitor the patient. I'm going to update the R50 with the patient's vital signs, any changes that are happening and about the patient's condition. So just going to prepare the area, make sure that we've got some space to the right of the patient, that there's space to move around the patient with and we're not too clogged in. And we could also consider travelling towards backup if backup's going to be a little while away. When the R50 comes here, we will discuss our roles and what each of us will be doing during the RSI. During the RSI, the ICP may also want me to apply some tracheal pressure, so we will do that by using the BURP acronym, backwards, upwards, rightwards pressure, so that they can view the larynx a little bit easier. I will also help the ICP with going through the RSI checklist with them, and also we will discuss what will happen should there be a failed intubation, and we'll all be made aware of what our roles will be during that time. So a failed intubation would be if they're unable to view the larynx within 15 seconds, or if they are unable to ventilate within 30 seconds. So we'd be made aware of our roles if there was to be a failed intubation and what would happen during that. So an intubation is failed if vocal cords are unable to be visualised within 15 seconds, or if the ICP is unable to intubate within 30 seconds of laryngoscopy. If there is a failed intubation, we may be required to assist the ICP with intubating via a bougie, where they will place a bougie in and we will assist in placing the ETT over the bougie. We will also consider manually ventilating the patient. We may be required to apply some further trachea pressure and ensure that the patient is still in a good position so that the airway is optimised. And again, on the second try of intubation, if the EtCO2 level does not reach over 5, which will be somebody's job to monitor, then that's a failed intubation and the tube must be removed. We will replace it with an LMA or an OPA, MPA, and we will ventilate from there. If ventilation is still unable to be achieved, then the ICP may wish to perform a cricoid thyroidotomy, which we may be required to apply cricoid pressure for.